So this is the story of how a team made up of 4 individuals, all from different disciplines, and brought together from different agencies, came together to improve the experience of homeless people in the Bristol Royal Infirmary and save the NHS loads of money to boot. So what we're going to look at, Ooh. Is it going to do the, oh, okay. What we're going to look at is identifying the need for such a team, proving that need to obtain funding, and then we'll look at who we are and what we did, and then we'll see the outcomes of our activity, and we'll look at a case study as well to sort of summarise. So first, identifying the need for a homeless support team. We've heard this morning, and we all know in this room, the basic facts that the life expectancy for a homeless person is in their 40s, that they are frequent users of hospital services, often don't have a GP of their own. They tend to self-discharge, and they've often got multiple morbidities, multiple medical conditions as well. I really can't see this. But why a homeless support team in Bristol? Well, various agencies, both within and outside the hospital, had noticed that homeless people were coming into the hospital and had specialised homeless needs that weren't being picked up or dealt with while they were there. A Pathways team came in 2016 to see whether the model that you have in London was transferable to Bristol, and they said yes, it was. And so a GP from Bristol carried out an audit to determine the impact that a homeless support team in the hospital would have on the hospital and its functioning. And she presented those findings to the CCG. And this resulted in funding for a homeless support team for 18 months, serving adults who are homeless and over 18 and who were frequent attenders in the hospital, A&E department, or who were inpatients. So the Bristol team, which actually has 4 members, I've recently handed over my responsibilities to Mike, who's also a GP. We're commissioned by the BNSSG CCG, Clinical Commissioning Group, who oversee us. We have a social work practitioner from Bristol City Council. We have a GP from Brisdoc, which is supplying GPs on behalf of the NHS. We have an outreach worker from St Mungo's. And we have Lucy, our registered nurse, who is our clinical coordinator, and who immediately prior to this was working at the Bristol Royal Infirmary, which has been a very helpful link. Over to you.
Cool. Thank you, Jenny. So I'm going to take you through what we did and what our outcomes were. So model of work, as we've kind of already mentioned, was based on the Pathways model. I've got a long list of sort of things that we were asked to base our work around, but ultimately we were asked to work in a holistic way. So looking at the mental, physical, social aspects of people's problems when they came through the door to the hospital. So looking at the complex right through to the practical, such as finding a pair of shoes and some dry socks and pants for somebody when they were ready to leave the building, which obviously are just as important as anything else. So this slide is really quite busy, but ultimately this is hopefully just to try and demonstrate what a patient's journey is through our hospital. And really, it's just to highlight that the whole point of what we were commissioned to do and asked to do was to be there throughout the patient's whole journey from start to finish in the hospital. So the idea was that we saw them as they came through the door, assessed them, identified what their needs were, what their issues were, what we felt they needed, what the client felt they needed, and supported them throughout their time, whether it was a couple of hours or a couple of weeks in hospital or longer, right through to the point where we would hopefully have a proper, safe and appropriate discharge plan to avoid them returning to the street. So, aims and objectives, or key performance indicators, as we like to call them. There were quite a lot of these, so I've kind of tried to break them down a little bit. So we had some performance standards, which were primarily around reducing the rates of admission and readmission, both to the inpatient side of the hospital and to the emergency department. We were asked to increase the number of homeless high-impact users or A&E frequent attenders to the hospital with a care plan, so that we know when someone comes into hospital, staff can access information to know what's going on for that client, what their needs are, and what the best things to do are for them when they come through the door and who to refer to. We also wanted to reduce the number of people discharged back to the streets and to improve the number of people being discharged with somewhere safe to go. So in terms of quality standards, obviously we wanted to improve health outcomes for homeless patients. I think that was a general theme throughout the whole of this. We wanted to improve the experience of hospital discharge, so trying to get away from this, you came in homeless, therefore you shall leave homeless, and trying to work out a strategy to prevent that from happening. There was a big drive to improve the quantity and quality of information available both to clients and services in the community, including primary care, when someone leaves hospital, so they know where to access help and for the people to know who should be providing that help. We wanted to increase engagement with primary care, which kind of tied in with the information side of things. We also wanted to understand the level of satisfaction with our service from both clients and staff in the hospital, so that primarily we could look at what we were doing, work out if it was working, and more importantly, if it wasn't, or if people were unhappy, to know what we could do to change that and start getting it right. So, outcomes, what did we achieve? So, did we reduce length of stay, readmission rate and self-discharges? So, in a nutshell, yes, we did. And I think we were all really quite amazed at the numbers we achieved, actually. I think on a day-to-day basis, we hadn't realised what we were achieving until we actually sat down and did the number crunching towards the end of the pilot. And that was achieved for both inpatient stays and the emergency department. So did we reduce the number of patients returning to the streets on discharge? Well, yes, we did as well. So for those people who came in who were identified as rough sleeping on admission, the majority, not quite all, but the majority, we did try to find somewhere for them. So their discharge destination wasn't necessarily the most ideal. At the very least, we had a booked shelter space for someone on leaving hospital, rather than someone leaving with the uncertainty of not knowing where they were going to go each night. So not ideal, but at least they had somewhere to go and they were plugged into the right people in the community who could help them move on when something more appropriate became available. It's also worth noting that we had a lot of people who were identified as living in hostels on admission to hospital. So pre our service, a lot of people were coming in, not communicating that they were in a hostel. The staff weren't asking about where they were living. There was no communication going on with the hostel or the council, and so people would come in, they'd be successful in having their treatment, and then they would have no hostel to return to when they left hospital. So we did a lot of communicating around making sure that staff knew to ask, patients knew to tell us, and then we would communicate with the hostels and the council to make sure those beds were safeguarded until they were ready to leave hospital. So in terms of improving registration with an appropriate GP, this is actually more challenging than it sounds, partly because you don't know until the last minute, if at all, where someone's going to be located. So you don't necessarily know which GP surgery someone's going to be local to. Processes across even just one city in terms of how someone is registered actually vary so much from practice to practice. Some can do online, so we can do that at the bedside. Others rely on you having to go into the surgery, filling out a number of forms, which poses problems for a lot of our clients. The other issue we had is there's still a lot of receptionists out there who don't realise they have a legal obligation to register people regardless of whether or not they have an address or proof of ID. So we did a lot of education around that as well. Some gladly received, some possibly not quite so. So I am rattling through this a little bit, but patient experience. So we gave all of our clients a paper feedback form to fill out during their time, anyone who'd met us. Return rate was really low, unfortunately, but the majority of people were really very happy with the experience that they had from our team. We did have one person who was very unhappy, and it's really unfortunate that they didn't tell us what they were unhappy with, so we weren't actually able to address those issues, which would have been a really positive thing to have done. We also did some filmed interview feedback with some of our clients who were willing. The main themes were really positive from the filming of all of our clients that gave feedback. A lot about giving reassurance and a lot about taking the pressure off, you know, the huge pressure of being homeless and what that is for them, which was really positive. These are some actual comments from 2 clients who gave us feedback. I'll let you read those yourself, but needless to say, they're very heartwarming, very reassuring, and we were actually really taken back. One of them actually had me in tears, actually, which is really quite moving. So, staff experience. This is always a bit of a contentious one when you're bringing in a new service and you're perhaps asking people to keep someone in an extra night or trying to get a member of staff who's harassed and very busy in the emergency department to accept someone's complex and challenging behaviours, possibly. So I wasn't quite sure what staff were going to say, but needless to say, it was actually really, really positive. Again, these are some actual comments that we received on our feedback forms, and really went a long way to showing the work that we did in such a short amount of time, really. And as we were nearing the end of our pilot and we were doing all of our number crunching and looking at our KPIs and wondering how we'd done, if we'd done well or not, we also discussed as a team that because of the way that we worked, we brought a lot of added value. So there weren't things we were necessarily tasked with doing or asked to do, but they were a consequence of the way that we were working. So again, there's a large number of things on there, and these may be things up for the Q&A a little bit later on. But it's really just to demonstrate that we brought much, much more than just what we were asked to do. And I guess the most important thing is we've now become a permanent hospital service after an 18-month pilot, which is obviously what we aim to do, and it means we can now go on and look at how we want to develop further. So I'm just going to pass you back on to Jenny.
Thank you. Thank you. So it was a pilot. And we had over 700 referrals in the 18 months. And mainly due to saving on bed days and on readmissions, people going around the revolving door, we saved the NHS £766,000, which we're very proud of. Thinking of the future, obviously we want to ensure that our service continues to work within the suggested framework of the new health standards. We hope to integrate the service further into the homeless health service that we have in Bristol and possibly extend it to the other major hospital in the north of Bristol. We'd like to audit around specific issues that we've come across, a recurring theme of, for instance, endocarditis in the patients that we saw, and we'd like to look into that with a view to prevention and better outcomes. We'd like to see the availability, possibly should have phrased this, step-down beds that we were hearing about this morning. The idea that people are ready to leave a hospital bed. They don't need the high intensity of a hospital bed, but they couldn't quite manage on the street. They couldn't quite manage in their temporary accommodation. In the same way that if I was in hospital, I might expect a family member to be able to care for me, this sort of thing. So we'd like to be able to look into that for Bristol. We hope to improve end-of-life planning and outcomes for our patients. If we consider the question, would I expect this patient to die within the next year? Quite a lot of our patients we could consider to be terminal. In the future, we hope to involve volunteers to support the patients in hospital, and especially those with lived experience. And we'd like to be more involved in staff education in the hospital on attitudes to homeless patients, as well as on the service we provide by means of a trust study day, and to be involved in the staff trust inductions. So we thought we'd summarise it by giving an example of a patient that we saw from the summer onwards, really, RK, who is 34 and was seen in the emergency department after vomiting blood and was found to have a very severe anemia. And she self-discharged once she was stable, but she was advised to have further investigations, a gastroscopy and a colonoscopy as an outpatient. She was living in a tent on Brandon Hill, which is a steep green hill quite near the Bristol city centre, with her boyfriend and another couple. She was an injecting drug user and had developed significant and painful leg ulcers on both legs. And as a result, she used a wheelchair, which her boyfriend pushed up and down the steep hill when they went for their methadone or they went begging. I take part in an open-air outreach morning once a week, along with an outreach worker and a drugs worker. And each week we went to Brandon Hill to visit her, and I would try and patch up her leg ulcers, as well as a GP can manage leg ulcers, and encourage her to attend the outpatient colonoscopy appointment that had been booked. She didn't turn up for that appointment because of the chaos of her life, and I asked her if she'd agree to an inpatient stay, and she said yes. So the Homeless Health Service worked hard to coordinate an inpatient stay for her gastroscopy and colonoscopy, with the added value of a visit on the ward by a dermatologist and a leg ulcer nurse. So I visited her tent to advise her of the date, and she laughed. And her boyfriend pointed out that that date was payday, and so she had no intention of going. So that was useful information, which I took back to the administrator, and we got a date that she would agree to. And the day arrived, and outreach visited her to remind her, and she was admitted to hospital. And the homeless support team was advised of her. We were aware that she was going to come in, and we were advised of her arrival once she'd arrived. She had the endoscopies, and she was found to have gastritis sufficient to account for her anemia, and treatment was begun. She was seen by a leg ulcer nurse, and she was seen by the drug specialist team, who advised her to split the methadone morning and afternoon dose to help with the pain of dressing changes. But from day one, the homeless support team was involved. We assessed her needs relating to her homelessness, whether physical, mental, or psychosocial, and then started to address those needs. And work began on finding her somewhere more suitable to live, ideally somewhere ground floor, because of the wheelchair. And because of her anxiety, for which she'd been self-medicating while she was in her tent, she almost left hospital several times, but regular visits by the homeless support team motivated her to stay. A ground floor room came up in Jamaica Street Hostel, which has the added advantage that it's joined to the Homeless Health Service with easy access for leg ulcer dressings and continuity of methadone prescribing. And the hostel asked her to attend for an assessment on the day of discharge at 5 p.m. However, on the day of discharge, time was ticking by, and she still hadn't had her afternoon methadone dose, which to her was her priority, far more than attending that hostel assessment. So the homeless support team was able to champion her need for the afternoon dose and make it a priority for the busy ward staff. One of us accompanied RK with her boyfriend pushing her in her wheelchair, the couple of 100 yards from the hospital to the hostel, just in time. And RK had to be encouraged not to miss the hostel deadline by her need to make a roll-up cigarette en route. As a result of this intervention, she's still living in the hostel 7 months later. She's engaged with the Homeless Health Service to deal with her gastritis and her leg ulcers. And because she's now in the hostel, she can more readily engage with GPs, key workers, and psychosocial inputs around her drug use. She's out of her wheelchair, currently using one stick, and comes to the nurses regularly for dressings to her legs, which are improving. And because she now engages with the primary care team, she no longer needs to attend hospital in the chaotic way she did.